Hi, before the meeting starts, the board needs to elect a chair just because there's an absence of the chair and the vice chair. So it's been suggested that Councillor Waller chairs the meeting unless there are any objections. Okay, lovely. Do you mind sitting at the chair? Thank you.
Okay, thank you for that vote of confidence, and welcome to this meeting, which works out to be my first meeting. Yes. So what I'll do is I will, because of the number of substitutions, and to help one of our speakers, just to go around and say who we are and which organisation we're from. So I'm Councillor Andrew Waller, City of York Council.
I'm Margot Budreva-Cute. I'm the Democracy Officer for City of York Council.
Councillor Janet Lucko, a member of the Health and Wellbeing Board. I'm not so, there is no substitute for me, so I'm here in person.
Councillor Denise Craighill from City of York Council.
Hello, my name is Brian Cranner. I'm the new Director of Operations and Transformation for TZESC and Weir Valleys NHS Trust in North Yorkshire, York and Selby.
Hello, I'm Carl Wayne from the City of York Council in the Communities team.
Joe McKaylee, Head of Communities at the City of York Council, presenting a paper later.
David Harborne, I chair the trustees of York Centre for Voluntary Service, and I'm a substitute for Alison Simmons, who couldn't be here today. I'm also on the steering group of Healthwatch.
And I'm Sian Balsam. I'm the manager of Healthwatch York, a project based within York CBS.
Hello, I'm Lisa Winwood. I'm the Chief Constable of North Yorkshire Police.
Hello, I'm Stephanie Porter. I'm the Interim Director for Primary Care with York Place. So the NHS bit.
Hi, I'm Peter Roderick. I'm a consultant in public health. I'm substituting for the Director of Public Health, Sharon Seltz, who can't be with us today.
Hi, I'm Martin Kelly. Excuse me, I'm the Corporate Director of Children's Services and Education.
Hi everyone, I'm Jamila Hussain. I am the Corporate Director for Adults and Integration.
Hello, I'm Tracy Wallace, the Health and Wellbeing Partnerships Coordinator. So I provide support to the Chair and to the Board.
All right, thank you for that. So that covers the apologies and substitutions. So that brings us on to agenda item 1, declarations of interest. Does anyone have any Specific, right, just for today's meeting, as I'm chairing, although it's already on the declarations of interest, I am school governor at York High School and at Westfield Primary, which I think is relevant to agenda item 7, Healthwatch, York report on children's mental health. And my partner is Councillor Stephen Fenton, who works for NHS England. Right. Okay, that brings us on to agenda item 2, minutes of the meetings held on the 18th of May and the 20th of July. And I've got them here. To people who were present at those meetings, prove that they are an accurate record of those meetings. I'm seeing consent to that, so thank you for doing that. Right, this an approximate timings sheet has been distributed, because I appreciate that there are members of the board who will have other meetings that they need to get to tonight, and we do wish to remain quiet to be able to make decisions. All right, that then, unless there's any objection to the proposals, right? Okay, that brings us on to public participation, agenda item 3, and I'm just checking with our technical people that Flick Williams, who is coming to us first remotely. Flick, can you hear us?
Good afternoon.
Good afternoon. Right, you have your 3 minutes to address the Health and Wellbeing Board.
I came to the meeting of this board back in May to talk about the disconnect between applying for age-friendly city status whilst disabled and older people who are dependent on vehicles to access the city centre remain excluded. The response from various members of the board was that wasn't the time and place to talk about the blue badge ban, which rather begs the question, when and where is the place? That big elephant is still there, sat squarely in the middle of the room. Since May, this council has received a postcard petition of 2,700 people who oppose this ban. The comments are testimony to the harm this ban is doing and the adverse effect it is having on the mental health of so many who are left socially isolated and feeling forgotten. This board is well placed to understand the detrimental effects on physical health and well-being from social isolation. Furthermore, this council unanimously passed a motion to adopt the social model of disability. It contrasts with the individual model of disability that tells us we as disabled people are the problem. We are the broken people that society discards and ignores because we don't fit neatly into the systems, structures and services provided as society currently sees fit. It is the you do you model. By way of illustration, there is another item on your agenda today, the COVID report, which is a clear example of this. The living with COVID strategy, or the business as usual response, is a shameful abandonment of clinically vulnerable and older people. In marked contrast to the beginning of the pandemic, when we had something approaching a social model response, where societal restrictions protected those vulnerable to the disease. Volunteers supported people who were shielding with deliveries of food and medicines. But now, albeit I accept, led by central government, we have a complete shift back to individual responsibility, which flies in the face of my understanding of what public health is and does. Safer behaviour messaging is woefully inadequate protection for those who are clinically vulnerable. It is not uncommon to hear that the only people dying now are people with comorbidities, like we don't matter. What this report, with its copious, indigestible statistics, doesn't tell you is the human realities behind them. I know many disabled and older people who are now declining medical and dental treatments because they do not feel these settings are safe. The survey done of concessionary pass bus users in the city shows many have not returned to pre-pandemic levels of travel, citing a lack of COVID safety. I even had a bus driver refuse to open windows for ventilation on the basis that other passengers would only close them again. It is why for many private vehicles become even more important to avoid infection, which brings us full circle to the blue badge ban. Does any of this sound like an age-friendly city to you? Sadly, it doesn't to me. Thank you.
Thank you very much, Flick Williams, for your comments, which will be considered when those agenda items are debated. Right, and next we have Dr. Marilyn Crawshaw in person.
Thank you. I'm speaking for Reverse the Ban, the non-party political coalition seeking to overturn the blue badge ban and reverse its impact on the health and well-being of disabled people, their families and friends, and of not yet disabled people who feel ashamed and disturbed by the council's actions. Its steering group believes that the ban jeopardises key parts of your health and wellbeing strategy and questions whether the city should go ahead with an application for age-friendly status while the ban remains in place. Our 27 member organisations are York Accessibility Action, York Access Hub, York Carers Centre, York CVS, York Cycle Campaign, York Dementia Collaborative, York Disability Rights Forum, York Human Rights City Network, York Inspirational Kids, York LGBT Forum, York ME Community, York Old People's Assembly, York People First, York Sight Loss Council, Accessible Arts and Media, Age UK York, Ageing Without Children York, Eleanor Worthington York, Different Strokes York, Healthwatch York, Lollipop, My Sight York, Older Citizens Advocacy York, St Sampson's Social Centre, the Wilberforce Trust, Unite Community York and United Taxi Trade York. And here are just a fragment of the 767 additional comments made on the 2,700 plus strong postcard petition submitted to full council on the 20th of October. And please note in particular the words discrimination, degrading and shame, all known powerful health stressors, causes of health inequalities and breaches of equalities and human rights. And these are the words. Disabled people need protecting from discrimination and degrading treatment. The council is taking away our freedom, equality, opportunities, our right to socialise and enjoy activities in the city centre. What have we done that offends the council? Why do they hate us so much? This feels like the thin end of the wedge. What have they got planned for us next? Another. I'm ashamed of being a York resident and born here. My mum died last month. She had MS for 40 years. Since the removal of parking and access into the centre, she was no longer able to be taken into town by my father. I was no longer able to take her to see a film at City Screen. The small things in life that non-disabled people take as granted. Please give us the opportunity to live as others do. Next, as a retired OT, I'm a strong advocate for people remaining as independent as possible. By stopping people from shopping, using the bank, attending appointments, etc., the council is preventing people from exercising their independence. And lastly, the social model of disability, which the council unanimously voted to adopt, emphasises that people have impairments, but what disables them are the barriers we place in the way of their inclusion. The blue badge ban is a clear example of a failure to remove the barriers to disabled people's inclusion in the life of our city. It's shameful, divisive and unacceptable. How can our ambitions around tackling health inequalities and building a city for all be taken seriously when council leaders took a decision like this despite being begged not to? How can we believe it when we say that we will shape the future of our city around what matters to our residents if we ignore the voices we most need to hear? Thank you.
Next speaker is Diane Roworth.
I am a disabled person and member of Reverse the Ban steering group. Reversing the ban on access to the city centre for blue badge holders is gaining huge momentum, particularly since the 50-strong peaceful protest in the rain outside the Guildhall, followed by the presentation of our petition to the council and the placing on public record of 767 postcard comments describing the heartbreaking impact of the ban. Labour and Green councillors 2,700 individuals, local and national organisations, including Thomas Pocklington Trust and Disability Rights UK, are all asking for this discriminatory ban to be reversed. We would like you to do the same, because it is affecting people's lives, causing isolation, exclusion and unhappiness, all the things that contribute to physical and mental ill health. Here are some more of the 767 comments. As a local resident, I feel I am excluded from my own city due to my support needs and disability. Life is hard enough as it is without this. I miss when York felt like home. As a carer for my mum and partner, I can't manage to take them both into the city centre anymore. As a blue badge holder, my life has been worsened dramatically by the ban. I can't access City Screen early evening anymore and places like Betty's. The impact of the ban has taken an intense toll on the emotional and mental health of myself, my friends and family. Visiting my beloved city centre is no longer an option. Allowing us to enter before 10:30 and after 7 p.m. causes blue badge holders or classes blue badge holders as second-class citizens. The new Health and Wellbeing strategy talks about achieving equality and how important it is for all council strategies to work together. This is one example of how an ill thought out and discriminatory strategy to remove cars from the city centre has a negative impact on the health and well-being of thousands of York residents. We ask you to follow the social model of disability, which the City Council recently adopted. Will you ask the Council to reconsider its blue badge ban, to uphold its public sector equality duty and human rights law? They will tell you they have to do this to keep people safe. We know there are other options and there always have been, but the Council don't want them. They only want a car-free city centre. Government Hostile Vehicle Mitigation Guidelines and the Martin Higgett report it commissioned gives them other options. If they are really wanted to be inclusive and welcoming city, they tell everyone they are, they would have chosen another option rather than a blanket ban. So please observe the social model of disability. Remove the physical and attitudinal barriers that are creating a two-tier society in York. Those who are included and those who are not. Make this the first step in implementing the health and wellbeing strategy. Make it known that in order to promote equality, inclusion, good health and well-being, you support the call to reverse the ban on blue badge holders entering the city centre. Thank you.
Thank you. The fourth speaker is James Cannon. You have to address the board.
Good afternoon. My name is Jim Cannon and I chair York Older People's Assembly. I also chair the Age Friendly Citizens Group, and you have a report in front of you tonight on the Age Friendly Citizens Group. I'm really glad that there has been significant progress through that group. And if you look at your report on page 61, you can see some of the issues which we have tackled and improved. And I would also like at this point to pay tribute to Carl Wayne, who has been a diligent, hard-working officer. York City Council should be proud of him. We're also pleased that there's been investment in improved pavements and the installation of extra seating, which not only benefits older people and disabled people, but younger people as well. However, there is one single issue which raises most concerns, and that is the blue badge exemption. The removal of that from the foot streets in the last few years has been terrible. It had a major impact on one of the centres for older people, which is St. Sampson's, and their footfall has dropped greatly. COVID has hit us all very hard, but it's hit older people harder. Apart from anything else, it's changed the life expectancy of the entire population, because of the over 200,000 deaths in the UK, most of them are older people. One of the consequences of that is that older couples are now older singles. People are on their own and they're isolated. And one of the key issues in the health and wellbeing strategy is to tackle isolation and loneliness. What the blue badge ban does is increase it. It stops people from getting out and about. General bus use in York is now at 90% of the pre-COVID level. For concessionary fares, it's only at 65%. People are afraid or unwilling to get on buses. And the blue badge ban has made it harder because those who have access through blue badges have not been able to get into the city. I was talking to somebody recently who said they'd been into the centre of the city twice in the last 2 years, whereas previously they used to go into the centre regularly. This is a major impact in terms of isolation and the mental health of people. The age-friendly York Citizens Group receives comments every month from citizens, and these are gathered randomly around the city. And in October, there's a dozen or so comments here, and a number of them are put blue badge spaces back, no chairs and tables on footpaths, no cyclists riding through pedestrian areas, more benches for people to rest. We need more seats in York, especially with backrest. We need a toilet. Have we got any in York? We need more seats with backrests. A minibus service east, west and north, south crossing the city centre would be a boon to people with limited mobility. The walk from current bus stops can be quite daunting. In September, we had extensive comments, bring back the blue badges soon. You must bring back the blue badge. You must make sure more space and better conditions for disabled people. You must create better facilities other than St. Sampson's for older people. A cup of tea and a sandwich doesn't really hack it. And that is where we're at. We're at the position where people who can only get into the centre with a blue badge are being banned, are being stopped from getting in, and that's damaging their health. And it's not good for us as a society. Can I end up?
I've given you 4 minutes.
Oh,
so
I was just going to say,
I've been very generous with
I was just going to say,
time, so.
I'd say this, there are positive views for the future, and I welcome the fact that the council passed a motion on the 20th of October, adopting the model of the social model of disability, and I hope it happens. And the Martin Higgett reports, and if anybody hasn't seen it and wants to see it, got a copy here, gives ways forward for the council.
Okay.
Thank you.
Thank you for that. Okay. Not every chair will be as generous with timing as I'm hoping. Right. Okay. If we can bring us on to agenda item 4, which relates to the ratification of decisions made outside of a formal meeting, thanks to the latest wisdom from the new Director of Governance.
Thanks, Chair. I'll just quickly say a few words on this. The last Health and Wellbeing Board meeting was cancelled because of the Queen's death and being in the period of national mourning. We had a number of decisions that needed to be taken last time, which are listed at point 3 of the report. They were discussed and signed off via email for a number of reasons, one of which is one of them related to a statutory deadline. We had to meet to publish a pharmaceutical needs assessment, and we had approval of the Health and Wellbeing Board members to sign these off. This paper ratifies that decision in public, just so the decision has been taken in that transparent way in public. It asks for board members to retrospectively approve 4 things. The first, and this gives a bit of an opportunity to do something else as well. The first is to approve the new health and wellbeing strategy for the city. That is included in the board papers in a newly sort of designed version. Previously, board members would have seen this strategy as a poorly formatted document by me. Now it's a nicely formatted document and hopefully expresses the the work that we went through as a Health and Wellbeing Board. I would emphasise, if you've got the printed papers, it's on page 52 and 53, our what we called our 6 big ambitions, which I'll hold up there. And then on the pages beyond that, our 10 health goals, which were really meaningful targets about the health of the population that board members wanted to see us make an impact on. So there's a very nice graphic that expresses that there. So just to draw members' attention to that, and we would consider today, if members are willing to sign this off, the launch of that strategy as of last week. It is now on the council website. It is formally the health and wellbeing strategy for the city for the next 10 years. So that's the first thing to ratify. The second is the decision to publish a pharmaceutical needs assessment. The third is the review of this board in terms of some of its membership with recent NHS changes. That review is starting to commence, and Tracy will be contacting people, I think, over the next few weeks just to design that process for review. And the fourth is about the chairship of the mental health partnership. That as a role within our system, which was carried out exceptionally well by the last occupier of that position. That advert is currently out with partners for expressions of interest for chairship of that partnership. So that's what we really asked for, Chair, is ratification of those 4 things.
Thank you very much. And just to confirm that NHS England are aware of what has been proposed today, and they're happy with our pharmaceutical needs assessment process. So we've had that confirmed by NHS England. Councillor Looker.
I noticed that this item is not here for discussion, and it's here just to formally confirm our email ratifications, and I'm not wishing to question that, but I'm very wickedly, Chair, using it because it seems to be the only place where I can pull together a number of issues that are very much on my mind and which I wanted to bring to the board for their consideration. Some of them have sort of popped up in a way from public participation. I'm not here to discuss the details of the blue badge ban and that because I'm not a member of the executive. But I wanted to share with you, looking particularly at the strategy of the health and whatever it's called, our joint health strategy. And I was reminded very much for some of you who attended a really quite surprisingly interesting workshop around changing cultures, which looked at ways in which we make decisions and the sort of decisions we make. And what was extraordinarily interesting from my point of view was that we created this ladder, which starts at the bottom of the realistic decisions and heads up towards the stratosphere, where I'm afraid this paper sits among the high-level strategic decisions. And what I think we don't do as a board is ground our decision-making in reality. And I'm going to give you an example of that, which has hit the news just the last couple of days. A coroner has decided that a child's death was a direct cause of the housing conditions in which that child lived. Now, that is not a high strategic health decision, but by golly, it's a realistic decision that some of us around this table could make. We could set ourselves a target that we are going to reduce black mold in our properties by, I don't know, we'll tackle 100 a year, 50 a year, but we will tackle black mold properties and we will deal with it so that within a time frame, give us a time frame, there will be no, at least properties that we are responsible for where a child might die. This has been an issue that's been raising its head ever since I became a councillor. I have had tenants complaining to me about black mold within their properties. And frequently the response I've got is, well, if you turn the heating up a bit, that will deal with it. In a cost of living crisis, it won't deal with it because people are turning their heating off. So I think these are issues. And I just throw that one out as an example because it's one that hits my, has hit my emotions. very strongly this week. But I pick up Jim Cannon's point about loneliness. We take a decision on one hand that exacerbates people's opportunities to combat their loneliness by making it more difficult for them to get to their social centre, which happens to sit in the middle of the city centre and has been there for a hell of a long time. I remember it opening. So I really do think, members of this board, that we go back to our organisations and we start to root our health and well-being decisions. If children have a better, healthy well-being support in school, perhaps their mental illness will not be quite so bad or will not escalate quite so high. I think there are things we can do, and I would have liked to see fundamentally realistic, achievable targets within our strategy, so that we say in 4 years' time, we'll have done this, and it'll be something we can deliver. So thank you for putting up with me, Chair.
Okay, thank you. Any other comments? Right, so Councillor Craghill, we are over time. We are over time, Councillor Craghill.
Okay, I'll be very, very brief then. I do agree with Councillor Look. I always look through these things to see where the most substantive actions might be. But on the other hand, I do understand that this is a high level strategy and that other actions will follow. And yes, up to a point, we do within our housing management asset management plan, we do have actions to tackle standing water, damp, and things that underpin things like black mold in properties. So yes, I just wanted to say that.
Thank you, and I'm sure the issue will be debated at housing scrutiny as well on an ongoing basis. Right, okay, we have the proposals in front of us. Are those agreed by the board? Thank you. That brings us on to agenda item 5, the report of the York Health and Care Partnership.
I'll start and then hopefully hand over to my colleague Steph. So I think this is a report that we bring for an update at each Health and Wellbeing Board, and it's in regards to our place board, and this is the board that came into being when the ICS was made a law, which was in July this year. So we're not going to go through the background of where it's been, it's in the paper, but just to go forward on the points and the current position. A lot of work has been done at place to develop our place board, and some of the updates are now that the ICB has got a transitional operating plan, and this is an agreement that we have now between our place boards and the 6 of them to have a consistency across the board. That is in place now and agreed. So the York Alliance has now become the York Health and Care Partnership as officially. There's still some work to do around delegation and delegating authority around. Does the place board have finance spending authority? Does it have authority to spend some of the NHS funds in a different way? And that's all still being worked out yet. And hopefully by April next year, we can have a fuller agreement of what those delegations will be at place. The membership is now we think right, because we've also got a terms of reference. So the terms of reference were signed off at the last board last month. A few weeks ago, Peter completed a perspective, and this is a perspective that talks about health and care and where we need to go. And it's a very in-depth report that was published. And outside of that, there were some overarching priorities and ways of delivering health across York Place. So in answer to some of Councillor Lucas' questions around how do we ensure that the health and wellbeing board strategy has been delivered and what are the priorities, we have actually agreed some of them at the place board, and some of the areas are the quality of services and care that's being provided. Is it safe care? Are people experiencing good care outcomes? The second priority is population health. I know we talk about population health in the most widest sense, but in the data that the population hub has now collected, we can actually go down to specific areas where we have clear deprivation or where we have a number of people with long-term conditions where we can start tackling the early intervention and prevention. And the local area coordinators, and I can see Joe here today, work quite closely with us and the social prescribers to do that. So that's priority 2. Priority 3 is around access to services. I know people have issues around general practice, and my colleague Steph might talk more about that, dentistry and planned care. So specifically looking at those health things. And then priority 4 is around resilient communities. How do we ensure that we have communities who are resilient enough to prevent people from coming into hospital? I know we always have conversations about discharging people early, but we've also had a lot of debate within the place board about how do we stop people from coming into hospital when they don't actually need acute care. And then priority 5 is around urgent and emergency care. And how can we have a responsive service that supports people more locally in their localities? So that's part of developing a lot of the Health and Wellbeing Board strategy, and the oversight will be at that place board. So I'm not going to go too much into the actual detail of it. I hope people have read the paper there, but just go on to the governance, because it's the governance that we have agreed last month at the place board as well. So it's really clear that we have specific groups that now have been set up, subgroups within the board that will look at delivering and making sure we achieve those priorities. So the next time Steph and I come here, we can actually give you a much more of an overview of where we're getting into the delivery of some of those priority areas. I don't know, Steph, if you want to come in.
I think just to pick up on the themes that we've touched upon already in our items, Jamila went through the priorities, what the key board members are doing at the moment, are populating those priority areas with actions that form our own sort of performance measures. So just triangulating that comment about ethereal strategic ambitions, and actually putting some key examples of how we're going to performance manage ourselves against that. So there'll be also some reference back to the cultural values survey as well, about how we mature as a partnership and work in the new way through the integrated care system as well. So yeah, some of this will look very familiar, but wrapped.
Okay, I just seek clarity on particularly reporting back on access to services priority area 3, general practice dentistry. I know I get a lot of correspondence about it as a councillor, really desperate. How we've been to find out what's happening.
Yeah, so through the place board, we have got a subgroup that's going to look specifically at that and how we measure that. So in the next report we bring here, it will be clear, and then we'll have some trajectories within that as well.
Thank you, that's very helpful. Are there any other questions? Councillor Craghill.
Thank you. Yes. I suppose the thing I'm grappling with, and I'm sure it's been discussed a lot and will continue to be discussed a lot, is how decisions on budgets kind of come through to here from the partnership board. Obviously, we've got minutes, and I do welcome that. I see that from April 23, the board will meet in public. I think that's positive, but obviously there are concerns as all these structural changes keep happening. What are those implications going to be for York in terms of budget and resources? And I'm just wondering, how is that going to come through to here rather than be reported as decisions already made when we get these minutes?
I think in the governance structures, there's lots of tiers of governance around how we then agree budgets. I think one of the good things about the place board is that it's both the local authority, our community partners and health making those decisions now, which is a difference than when it was before, where it was health making decisions and then the local authority. So the board is very much a board made up of key partners who are then making those decisions around the money. Alongside that is the Better Care Fund, and then you have the ICB that meets, and I think that's also a public meeting which actually talks about all the decisions that the 6 places are making. We're hoping that by the time the papers come here, there are other arenas where things are discussed, like the Better Care Fund is discussed within scrutiny, as well as other council boards, and including the NHS governance. So I think there's clear levels of that, but hopefully in the reports, because the board is just maturing in a way, we will be able to demonstrate how those decisions are being made in a collective way.
Okay, any other questions? If not, do we agree the recommendations in paragraph 6? That's approved. Thank you very much. Right, that brings us on to agenda item 6.
Thank you. So this is the report for the approval of application for World Health Organization status as age-friendly communities. So just as a case of a little bit of background, in 2019, we put a proposal to the Health and Wellbeing Board to use this toolkit as a method to be able to engage with various considerations from an age-friendly perspective using the World Health Organization checklist. And we broke that down into a series of domains and created what we called a baseline assessment against those domains, which is basically an as-is, consulting with the citizens of York and stakeholders to both understand what the key issues are, but also what recommendations could be brought forward through the age-friendly citizen group, which we set up, and then on to the Ageing Well Partnership as an arm of the Health and Wellbeing Board. And we've now completed that on the 3rd of November, and the domains were getting out and about, your information, your time, and your services in your home. And quite interesting to hear the comment from Councillor Looker in terms of the recent news about the 2-year-old death, and the most recent one we did was your home. And we're aware that the housing team were carrying out a stock condition survey, and that will lead to a health impact assessment. And the Ageing Well Partnership agreed that we would sign it off as an interim report to your home, because we wanted housing to come back to us to report on the key findings from those pieces of research and adjust the recommendations accordingly. So I outlined in the report some of the key things that we've been doing. It's very much done as a code-produced approach, and it's very much done on the basis of starting off with the citizen and what's important to them. And again, that aligns with some of the comments that Councillor Looker was making earlier on in terms of the decision-making process and empowering citizens to be part of those solutions. And I've given a list of some of the things that we've been involved in, and just a couple of additional examples that happened over the last week really is that there's a lot of people that were coming to me from either as individuals or community groups that were having various issues around community transport. And because we had Age-Friendly York in place, I was in a position to call those people together to be able to discuss in one room what the key priorities were and how we could move initiatives forward. And another example was that there were some customers through my site, that are blind and partially sighted, that wanted to engage in the various community venues that are available, and how they can be accessible and how they're assessed as accessible. And one of the organisations we commission is Accessable. And there we've teamed up, Age Friendly has teamed up with My Sight and Accessable to provide an opportunity for people at blind and partially sighted to go through that process and understand whether that meets their requirements. And you'll see at point 14, we've kind of identified 3 of the potential options at the time of writing the report, and either to apply for WHO status, World Health Organization status, to remain as an age-friendly community, but not to apply at this particular point, which would be putting the proposal on pause, or withdraw from the age-friendly community status. And I provided some information in terms of the analysis there as well, and I won't go into great detail about that. But considering the comments that were made earlier on from the speakers, we would like to recommend that we put on pause the application for the status to engage with the range of community groups that have expressed a concern around this, to see whether we can find a positive and constructive way forward. As I say, we've worked all the way through this process over the last 2 years in a co-produced way, and it wouldn't feel right to not take and listen to the comments that have been made today. I think it's really important to state, and I stated in the last, when I presented the annual report, where Flick made some comments at the beginning of that meeting, and I stated that the age-friendly approach is a journey, and that's really important to understand, that it gives us the opportunity to understand what the key issues are, try and identify solutions, of which we've created a number of them already, and move through that journey towards an more continuous improvement from an age-friendly perspective. It's not around the concept of being at a destination. So it's a question of engaging with the community groups and saying, right, well, what is the right time to do that? Because what we don't want to do is throw the baby out with the bathwater and remove ourselves from the situation.
I'm going to have to move this on. We took more time listening to the speakers making the points that you're just discussing, and therefore it's curtailed the amount of time available for this item.
Okay. Yeah. So that is my recommendation, that we seek to go on pause until we feel it's more.
And just to clarify, that would include consultation with an about to be appointed access officer.
Yes. So I'm aware that and that will be a key post that will help to influence the changes that would take place.
Right, Sean.
Yes, I'd just like to say I am wholly supportive of that approach. I think this has been a commendable process. I join with our public participants in thanking you for the work you've done on leading this and demonstrating what it means to keep people at the heart of the work that we do. I think for me, it does highlight a bit of an existential crisis in terms of who I thought we were as a city and who we are at the moment. And I think we have to resolve that to move forward together before we can apply for WHO status. So I think you're absolutely right, and I fully support that approach. Thank you.
Hey, David.
Thank you. I'm going to echo Sean's comment there. I feel, unfortunately, that there are a number of areas where the trend has been going backwards in terms of being age friendly, of course highlighted by the public speakers. I don't need to repeat that, other than to say that the decision to allow pavement cafes improved footfall in the city, there's no doubt about that, but caused enormous obstacles to people with mobility problems trying to walk through the city streets. And if we are to continue with pavement cafes, the license terms must be enforced to ensure that older people and other people with mobility problems can walk safely on York's pavements. But it's not just there. A number of services are increasingly accessible essentially only through the internet, with other options being very much a second best. And I saw the report just this week of the fact that the council now accepts, for example, that mistakes were made in introducing the new online system for residents parking. A lot of residents don't have access to the IT systems that are required to get your license to park or to apply for visitor tickets, as a result of which some older people are advising their friends that they should not bring their cars because they won't be able to park on the street near their home. Now, that's just not acceptable. But it extends more broadly than that. If we are to be an age-friendly city, it means all of the people represented around this table have to take their share of it. And when you I understand the pressures to move online, I really do. But when you look at things like online triaging for GP surgeries, that is extremely difficult to navigate, even for me, and I'm IT literate. If you're not IT literate, how do you cope with that? And the alternative of phoning the surgery to be told that you are number 36 in the list, which I did on an occasion of a recent emergency, you're not going to persist. And I did not persist, and in the end called 111 instead. We have to think about how we make all of our services properly accessible to everyone, regardless of their access to IT. And we have to make sure that our streets are safe to walk on. And that's why I would certainly endorse the recommendation today to put this on hold. Thank you.
Thank you. Councillor Looker.
I had hoped at first when I looked at this paper that when you said age friendly, I thought you might mean every age from 4 to 74 or 84. We used to have aspirations to be a child-friendly city. I don't know whether we've abandoned those aspirations. I haven't seen anything about it, but it always struck me that a city that was friendly to a mother with a pushchair was probably equally friendly to somebody with a wheelchair, because both of you need dropped curbs and you both need to be able to get into shops and cafes without having to go up 3 flights of stairs. So I think I would like in my heart to feel age embodied every age, not just the over, what is it, over 50s, over 60s? I lose track of who's elderly these days. But yes, I mean, I do recognize it. What I think, and the previous 2 speakers have emphasized it, what I think it means doing is that we are prepared, if we're going to participate in this, that it will mean difficult decisions on our part as well as on everybody else's part. If we're genuinely consulting, we have to make it meaningful. Okay. Too many consultations end up with them saying, well, we listen to what you have got to say, but this is what we're going to do. Right. And please, let's do consultation that means something.
Right. We're now well over time, so if you can keep your comments brief, please.
Okay, well, I was just going to say I do agree with Carl's proposal, and I just had a quick question, but just as a sort of precursor to that, just to say there are things that are progressing, and cafe licenses is actually a published paper now for executive next week, which will actually change that situation. I hope will be seen positively from an access point of view, and other things are happening. So what I wanted to ask, well, but there does need to be a lot more, obviously, as well. But is there actually built into this process? You say it's an ongoing process. Is there a kind of evaluation and assessment process in there that we could actually use to help us?
Yes. So the way that we've approached it, so it's accessible as possible, is we've got an action plan and then we've got a progress on the page against any action point. And so there's the opportunity through the age-friendly citizen group to say, these are the things that we want to concentrate, also based on some of the comments that Jim Cannon has made. You know, we use very old-fashioned methods like having a suggestion box in St. Sampson's. So that drives, it's very citizen-driven in terms of what's on the action plan, but also what we prioritise and move forward. So that creates that accountability both to the citizens, back to the citizens, but also to the Aging Well Partnership.
Okay, right, the recommendations amended have been tabled. Are those agreed? Thank you. That brings us on to agenda items 7, 8 and 9, which we're taking as a block to ensure that there's sufficient time to debate those issues which are of interest to the people sitting around the table. Thank you.
Thank you, Chair, and you'll be pleased to know I don't intend to talk very much, which is very unusual for me, but I know we are behind time, and I'm going to take them all in completely the wrong order just to confuse people a little bit, because I like to do that too. So the first one I was going to just mention is the York Voices report is just for information. It is a summary of the things that we have heard so far, and some of those things have fed into things like the prospectus, so I don't think we need to dwell on it, but you have that information there. So if you are thinking about things and wondering what people are saying, it's all wrapped up there nicely in a report for you. In terms of the accessible information report, we were asked to bring back an update from members around the table about what we are each committed to doing in terms of making sure our information for people in the city is accessible. We've had some responses. I think there is some work to do. I know Steph has sent some emails about what the I keep wanting to call you the CCG. I'm sorry. The York Health and Care Partnership are doing, and I think there's something about how we put that into a sort of formal response that we can add into the report. We are still waiting for a couple of responses, so it would be really good if we could have those as a matter of urgency from any members of the board who have yet to provide them. And I don't know if anyone else is here from, I know Emma normally comes from the GPs, so I will pick up with her again, because I think it might be that we can do something joint between York Health and Care Partnership and the York Health and Care Collaborative that would give us that response. So I won't dwell on that. In terms of our report about children's mental health, I just wanted to highlight to the board that this is, like our GP Snapshot report last year, a different sort of report for us. We haven't gone out with a survey, campaigning, encouraging people to talk to us. This is literally what has walked through our door. This is what people have talked to us about. And it is, for us, the opportunity to start a conversation about something that we don't think we have heard enough about so far. We think there is more work to do around children's mental health, around the approach we're taking in the city, and around how we get more people to feel confident that they are able to access the help and support they need at the first sign that a child is experiencing some challenges around their mental health and well-being. This isn't just a report about Tees, Esk and Wear Valley's children's mental health support. It is about us as a system, and I think there's a conversation to be had there about each of us, our role in that, and how we make sure that every young person in the city gets the help and support they need when they need it, and are fully aware of all of the options available to them. So this is intended to start a conversation, not to finish it, and I'll stop there.
I just had one question which related to the recommendation 10. Relating to agenda item 7, which was to understand what happened next, because I think that is a crucial issue. So once organisations have their 28 days to respond, I think there needs to be clarity and amend the recommendation to include a site as to where that's going next. Is that a report back to this organisation?
If that is what you would like, that is what we will do.
We'll take a vote on that, but I'm very keen that it did. Ryan, did you want to come in?
Yes, please, Chair. Obviously, from the report, there are clearly a lot of concerns being expressed by people who have specific experiences in relation to specialist CAM services. And it's just to be absolutely clear, we welcome receiving that feedback. And that's the only way we can improve the experience that people have accessing the services. I think that said, you know, it very much is no one agency can provide or meet the emotional and mental health well-being needs of all young people in the City of York, and that working in partnership, using the model, giving various routes of access and support at different levels is really, really important. And the Trust is absolutely committed to working with partners to achieve that. Clearly, there's some communication issues here. Some of the families that are expressing real frustration with the service seem to be very much linked to some of our neurodevelopmental assessment, which is one of the most challenged areas that we have, with significant waiting times and high levels of referral. But clearly, we've got a lot of work to do to explain to parents and families what that process is, the fact that there are lots of forms to fill in. It is a very paperwork-driven assessment process, but clearly we do need to communicate that and ask our partners to communicate that pathway to families as well, so they set out with a clear explanation of what process is. And we're happy to respond in detail to the recommendations.
Martin, did you want to come in?
Yeah, I think certainly welcome the feedback, as Brian has said. I think what's important for me is that we perhaps don't look at this as just a local issue. It is a national issue, and there's some debate to have at a national level, particularly around how we consider it's very similar to the discussions we've had earlier on around a medical model or social model of intervention. And increasingly, I think what parents are asking for and what children need is a social model of intervention, less assessment and more doing. So I think it's how do we do that nationally, really, and how do we have that debate nationally?
Good. Jamila?
Yeah, just a couple of points, Brian. So and I think a lot of this in the report we have discussed with CHWBB and other partners, because I don't think it's just a specific CHWBB issue, but there are some things in here that are in CHWBB's gift. And what I haven't seen is, we talk about the I Thrive model. I think that's not communicated very well. It's not understood very well. I think a lot of the children who are coming into CAMHS may not need CAMHS, but they wait so long in CAMHS because the communication is not quite right, and then do end up in Tier 4 services because they waited so long. So some of that responsibility, I do think sits quite rightly with CHWBB to get that right information out, because I can, from a commissioning point of view, give information out from a council, but when it comes from CHWBB, we just need to be really clear. When we talk about I Thrive, if you go and speak to parents and you say to them, we've got an I Thrive model, they don't know what it is. And that causes a lot of delays. And some of the things in the report talk about schools not understanding. Equally, they will not understand that language. And then around the referral and assessment processes, I think what we've tried on a number of occasions, and we even wanted to pilot, and we never got to pilot it because all the other agencies were really quite keen to support. So we got Joe Michaela's team from a community perspective, the LACs, adult social care, children's social care, and what was missing within that schools project was a mental health person. One half a day a week we needed them, we didn't get them, so it all fell down because the whole project was around enabling parents, once they drop off their kids at school, to have a conversation with a mental health practitioner about their child or young person, because it was across primary and secondary. But I really want to know, how can we then start having those conversations, because a lot of this is not new, but equally some of the timescales about when we're going to have a slicker referral process, some of the communication, and then when we do want to work together to jointly commission, some of those timescales from now to sort of April and beyond, what is that going to look like? So that's just my slight pushback to you, Brian.
Do you want to respond to that? And I'm particularly keen to understand your connection linking with school pastoral teams who have commented to me about some of the issues that they faced.
So I think what I will play the card of, I'm new into post. So a lot of the historical discussions I haven't been party to. I think what I would say is that there is an advantage at the moment in terms of we have a new senior leadership team within the trust in this area. We are established as a care group board now, so really focusing on our services that we provide across North Yorkshire, York and Selby. So the previous discussions that have taken place about how we drive forward that I Thrive model, that working together with partners to provide that whole scope of support to families, and of course that kind of post-diagnostic support as well, because it's fine getting a diagnosis, but then what support do you then get after that? And again, that's about the whole system responding. So I can give that commitment in terms of refreshing that, look at what needs to be done, what can we revisit that we drive forward those changes, and how can we involve families with this as well, so that we co-create the service developments in the future. So I'm keen to be heavily involved in the development of the services going forward. And that includes involving schools, pastoral care, that they form a fundamental part of that whole model of support for families.
I think it would be helpful if in the 28-day response you can give a projected timetable on what would happen when we would see those results, just to keep this going forward. I've got David and then I've got Peter.
Thank you, Chair. It's an extension of the same point, actually. I was a governor of Selby College for 6 years and saw at first hand the increase in numbers of young people reporting various concerns and problems, up to and including suicidal ideation, and the way in which the college itself had to develop services to provide mental health first aid, and sometimes more than that, with ongoing counselling supported by volunteers from York St John. One of my concerns was that Selby College did all of that in isolation from the rest of the educational community. Now, I'm less familiar with what happens at York College, but I would bet you any money that York College has a similar setup. So when we're talking about sharing good practice, can we please not just talk about the schools, but include York College and Askenbryan College as well?
This issue was discussed at the schools forum, and they are part of the same system as schools within the city, so they're not in isolation, and actually they offered more resource to increase capacity, which is, I think, a very positive step. Peter.
Thank you, Chair. I remember Chief produced some work about 3 months into the start of the pandemic, modelling essentially of the demand that they were expecting to see as a result of the mental distress that we knew the pandemic would be causing. And I guess I raised that because we knew at the time that this would be a population problem, and that actually the sort of the waiting list issues that lie behind much of this would be a simple equation of there's more demand than the current national funding for mental health services is able to absorb in that sense. So 2 points. First point is that there's a population prevention thing here that we've got to get right. We fund through Public Health York Ending Stigma and the work around public mental health. And I think we have to do everything we can to try and prevent as early as possible. The second point is a lot of this seems to be waiting list based issues. This is a moment in time, and it's very much what people are feeling at the moment. What's the trend from a waiting list perspective? Are we heading in the right direction, or are we still on the up in terms of just pure months waiting?
So in terms of, it depends what type of referral. If you look at referrals coming into a generic team for mental health assessment, we are able to see young people within 12 weeks, which is not as quickly as we would like to see people, but it stands well in comparison to some other services. For urgent referrals to the service, we're able to respond within 2 to 3 weeks. And of course, we've also got a crisis service in addition to that. The real pressure, and again, it mirrors the national position, is around the neurodevelopmental assessments. And those waiting times are it's between 1 and 2 years, depending on the particular situation that individuals are in. There has been a reduction, a slight reduction in that waiting time, but it's we were at up to 3 years at one point, but it is a very challenging situation to remain within those timescales and reduce them.
Thank you, Councillor Looker.
Yes, just 2 or 3 quick points out of. I'm taking all 3 of them in the order in which I think of them. Just picking up on the issue around students. You mentioned York College and Askenbryan. We took a very useful paper some 4 or 5 years ago to review the issue that the student population in York, and that includes the 2 universities as well as the 2 colleges, put on the city is enormous. And as you say, a lot of them have to undertake a lot of mental health support work within their own environment. And I think at one point there was an effort to pull together and jointly share some of these resources, because it is interesting. A city the size of York has what is actually a very vulnerable young group of people coming out of their home environment and coping with the stress of coming to university, which can tip some young people just over the edge. So I think it is a very important area, and one which we need to pay particular attention to. The other one, and I'm sorry, I don't see anybody sitting around the table here from the hospital. It was a point that was made in your York Voices, I think, around York healthcare services providing adequate accessibility and understanding of the distinct needs of disabled people. Now, there was an issue that came up just recently in one of the papers around a very deaf patient who had been denied access to hospital with her hearing aid dog. Now, that seems to me they ought to rank along with guide dogs for the blind. I know they're not so prevalent, but hearing dogs can give people not just that little bit of extra support, but often a lot of emotional support in enabling them to cope with a difficult environment. And I was hoping to ask somebody, but there's nobody here, unless somebody's going to volunteer, to ask what that situation is and can it be resolved more appropriately. And I think my main thing around the Healthwatch Children's is children don't stay children for very long. There is such a huge urgency to dealing with a situation with a child, because it'll escalate, and what children don't have is very much time. You stop being a child far too quickly. And if you're having to wait a long time, the problem may change, it may get worse, it may differ. It really does need to be dealt with, at least initially, very quickly, so that you can catch a child while they are still, hopefully, at a position where they can be well supported and assisted.
Thank you, Councillor Jamila.
Just a quick few points. I think, Brian, I was just thinking about Public Health did a school survey. It captured a lot of young people, and it was really, really quite helpful. And one of the things that the school survey that brought out, and I think in this report, Sean, so thank you very much, it brought out around children with disabilities and the effect of their mental health, Black, Asian and other minority ethnics, and how we're we supporting those young people in a different way, and the LGBTQ people who identified as that, and people who also identified as non-binary. And what I didn't actually see, and maybe a part of your redesign about how we're going to support those individuals quite specifically, because they had quite specific needs, but the support they needed was quite quick. And I know there's a time scales on sort of 12 to 18 weeks, but some of those young people had particular needs that schools may not be able to support, or colleges might not be able to support directly around mental and emotional well-being, but something to consider whilst you're doing your redesign of iThrive.
Thanks for that. Councillor Crackle, did you want to comment? And just flagging up that.
Sorry, be quick. Yes, I'll make quite a big point, but quickly. Yeah, just alongside everything everyone said on the young people's one, I was thinking particularly the children one, alongside what everyone said about dealing with what's coming towards us at the moment. Just looking at the strategy that we looked at earlier, and we talks about prevention and starting young and good health from young flourishing lives. I know a lot of this is beyond our control, a lot of it's to do with national policies, but what can we do looking systematically to prevent this kind of deluge of mental ill health amongst young people? You know, in my view, some of it is due to the curriculum in schools and the pressure that puts on people and what's on young people, and just a number of other pressures to do with being a young person now, you know, to do with the internet, to do with worry about the future. I think we just have to try where we can to think about how can we prevent some of this.
Okay, thanks for that. Sean, did you want to come back in? Sorry, I'm interpreting. Maybe it's you're taking notes frantically, and yes, that's what your pen was indicating. Right.
Actually, sorry, I should just say we had feedback from one of the families that told us their story, who wanted to just let us know that since they told us their story, their communication has improved. And they said it doesn't change the time that you wait, but it does change your feelings about waiting. And if we can reduce that frustration for people, we're part of the way there to making people feel like they're part of a partnership approach to this.
Yes.
Parents, schools, people working in the system.
Communication is important.
And communication.
There's now letters, you do get updates to say, yes, your application is being actively processed, but whereas you previously, there was the worry that you'd just been forgotten about. So I think it doesn't take away the length of time of waiting, but at least it makes...
It eases the pain.
Yes.
Yeah.
Okay.
Can we just confirm the recommendations in each of the reports? Because I think you wanted to change one slide.
Right, so if we're asked to receive agenda item 8 and 9, and with agenda item 7, the Healthwatch report on children's mental health, I'm using my prerogative to amend it to include a report back to this committee. So with that addition and receiving the other 2 reports, is the board in agreement? Thank you. Right, that brings us on to the Better Care Fund update. Well,
not too much to say about the Better Care Fund, but this is a update that we give quarterly to this board. I think in particular, this update is that we have actually put forward our 22-23 plan for the Better Care Fund, which is within the document, and clearly highlights all the schemes that are in the Better Care Fund. So the Better Care Fund is a mechanism that a national mechanism that supports the local authority and our health colleagues and our community partners to work together to support reducing admissions into hospital, supporting people out of hospital. So I don't like using the delayed discharge because not everybody is a delay, but I'm going to have to use it at this term. So reducing delays in hospital, but also making sure that we effectively use reablement and support the reduction of people going into long-term care. So the plan clearly highlights how we as partners are going to do that. There is £20 million that runs through the Better Care Fund. Not all of that is new monies, but some of that is within some of the schemes and current contracts we hold. But but colleagues through the Better Care Fund group are going to look at some of those schemes and say, are they effective to delivering the 4 areas that I've just talked about around supporting people to stay out of hospital if they don't need it, but also discharging them sooner. At the back of the report, we've put in some of what we call our high impact changes. So as you can see that we've brought a lot of stuff or services into play that support that early intervention and prevention. I think previous reports that we brought relied very heavily on how do we discharge people out once they're in. And a lot of the conversations we've been having as a group is to say, well, isn't it the wrong way round when we try to get people out? Shouldn't we stop people from coming into hospital sooner and they remain in their own homes? So that's one of the areas that we've concentrated a lot on, and I hope the report sort of brings that out. So really, Chair, it's just to know particular things around early intervention and prevention is new in this particular reiteration of the 2023 report that's gone forward. NHS England have received our report and have agreed with the recommendations we put in, and also the monies that are a part of the Better Care Fund. So that's all I wanted to say on that one, not too much.
Thank you very much. Are there any questions, David?
Yes, I hope this isn't a stupid question, but do we really spend only about £44,000 on home from hospital? And if so, is that a reflection of the impact that home from hospital services has? Or is it a question that actually resources are so limited we can't increase the amount of support we give to home from hospital?
I think with the schemes, we are reviewing them all because, like I said before, some of the schemes were focused on discharging people out of hospital. As we go forward, we're going to have a focus on the early intervention and reducing the number of people going in. We are going to review all the schemes that we've got to look at what schemes would we want to put more money in, such as the one that you've mentioned, to keep people out. And that's the work that we're going to do over the next 6 to 12 months.
Might I just add that that's a specific scheme delivered by a particular organisation funded by the Better Care Fund. That goes without saying, but there are other wraparound services, so community rehabilitation team, the integrated care team. So it doesn't sit in isolation. That's one scheme that is funded through the Better Care Fund.
Thank you, Stephanie. Any other questions? If not, we're asked to note the report. Thank you. Anyone in agreement? Good. Right. I'm just going to take items 12, 11, sorry, 12, 13, 14 before item 11 to ensure that they get dealt with fairly. So, Peter, do you want to kick off?
Thank you, Chair. So yes, item 12, health protection annual report. We've been bringing a report on health protection for a number of years to the board annually. Until a few years ago, I would have said this is the neglected area of domain of public health, but it doesn't feel like that anymore after COVID. And in fact, this does link into the next item on the Director of Public Health's annual report, which also focuses on the pandemic. And I won't go through this line by line, but the health protection assurance report gives the board assurance about work that is going on that covers our sexual health services and key aspects of those, including looking at HIV late diagnosis, our chlamydia detection and opportunistic screening programs, a recent thing that our sexual health service has been very closely involved is the response to the national outbreak of monkeypox in one particular community that we've been working on. It also talks about our efforts for vaccination, and they're thinking, I guess, about COVID and flu in sort of one box, and the large effort that is ongoing in the city at the moment to increase uptake of both those two vaccinations against respiratory disease, but then the ongoing vaccination schedule, which covers all ages, and particularly thinking about our children and young people and ensuring that they have a healthy immune system through vaccination. So there is data around how we perform as a city on that. It will also, the report also does cover and talks about the healthcare acquired infections group and the work that we do in clinical settings to try and minimise rates of healthcare acquired infections, MRSA, C. difficile, E. coli bacterium infections, etc. It talks a little bit about oral health and some of the work we've done recently through public health, for instance, to do some of the flexible commissioning work with dentists, where for particular members of our community who are particularly vulnerable, given the problems we have with dentistry in the city, to flexibly commission places for those individuals so that they can get the care they need, but also some of the public health, oral health promotion, and a new scheme that we have with a number of schools and health and childcare settings in the city to try and improve oral health. It also covers screening, the 4 NHS screening programs of AAA, breast, cervical and bowel cancer screening. And in the end, at point 13, it talks a little bit about infection prevention and control, which is delivered by Harrogate District Trust on behalf of the city, and the great work that team do to try and keep us safe from infection. So it really does give a jolly good broad overview of all the things that go on under this domain, and it's really for the board to note and ask any questions or comments on any of those areas.
Are there any questions to Peter on that report? Councillor Looker.
Yes, I'm slightly bothered by a low take-up of some of the vaccinations, particularly for children. I was looking particularly at the HPV, which seems to have gone down very hard from a high of 71 in Yorkshire and Humber to only 53% in York. And I just wondered, I think you're saying, there has been some difficulty with it. Are we taking any more proactive efforts to try and improve this one? I don't know if, I can never remember anybody's names these days, but our education, wonderful. Yes, whether you want to comment on some of these school-based take-ups.
I can give a bit of detail, Martin, on the school immunisation programme, and then Councillor Martin, obviously, about the specific work of schools. So I think it's fair to say school immunisation services have had an interesting few years. I'm particularly thinking about the COVID vaccination programme that has been delivered. And we know that take-up of HPV vaccination is not what we want it to be, and we want that to be higher. It's been expanded to both girls and boys in the last 2 or 3 years, so there are some essentially we've expanded the cohort by 50%, and very much work closely with that school vaccination service to deliver that. I think inevitably there has been a COVID impact there, which we're working through like every other backlog, but absolutely take the point back, Councillor Looker, to our teams that work with Harrogate who deliver that to make sure that they're aware that that's been noted in this venue. Don't know, Martin, if you had anything more.
Okay.
That's okay. I have nothing to add. I think as much as possible is being done. I think it's consistent again, nationally, regionally. It's not something that's unique to York, and I think it's something that will take some time to pick up. To be quite honest, in terms of post-pandemic and children getting back to school, parents getting back to normal. But I think it isn't just a York issue.
Sharon, that is an indication to speak.
Yes, sorry, I'm going to have to work on that, aren't I? I often lean on my hand and then every now and again I go like that. It's not helpful. You'll be unsurprised to know I was looking at the bit about dentistry because I can't let it lie. I will not let it lie. I was really, really happy to see the things about the oral health promotion service. And particularly that all of the, I don't like the term special schools, but I know it is the one we use. All of the schools in York, North Yorkshire, for pupils with additional needs will be invited to take part in supervised toothbrushing. But one thing I wondered is, can we actually link that with signposting to the community dental service? Because it constantly surprises me how we don't signpost those children and their parents directly to that service. And as it's the same provider, that should be something we can feed in relatively quickly. And also thinking about dentistry and referrals into the flexible commissioning programme. It's great that we have a couple of routes through that in terms of the healthy child practitioners or social workers, but are there any plans to increase that? Because I know in other areas they have allowed referrals from social prescribers and from Healthwatch information officers where they are coming across cases that they do not have a solution to. And I know for a fact we have a number of cases that we do not have a solution to. I've raised it with NHS England and others about what is the referral route for us, and they cannot point me at one. And I think where we are coming across cases where people need a referral, we've heard from GPs who don't know who to refer them to. There needs to be a process that we are all clear about, that we can all access. So can we do something to sort of join that up a bit, please?
I mean, Chair, if I might suggest we take as an action from this that I find all that information out, because I have to confess I don't know the answers for those, but we can take as an action to next meeting an update for Sean on those
that would
particular
be
issues.
important. I'm aware that there have been some changes to the number of antibiotics that you had to do 3 lots of antibiotics before you can be referred to emergency dental care, which is a concern, and there are attendance issues where families are only having to go as far as Manchester to get dental work done with their kids. So the ramifications are tremendous, not least the amount of pain that children are going through in the meantime. So Peter, if you can make sure that it's circulated to all, because I think it's something that across the city there's interest in. Okay, people happy to note that report? I think it's Peter again.
Thank you, Chair. And I at this point should very much state that this next report I'm presenting on behalf of Sharon, who sadly can't be here today. It is Sharon's report. There is a statutory duty on the Public Health Director in every local authority to produce an annual report on the state of the city's or the area's health, and this is ours. This, for quite understandable reasons, covers the years 2020 to 2022, and we have called it the pandemic years. And there has been a Chief Medical Officer report in York stretching back to the mid-19th century, and we can go into the city archives. In fact, we did when we were writing this, to look at some of the previous CMO reports for York. So in some senses, this has a historical aspect as much as anything else. It captures the story of the pandemic in York. It tries to reflect both the epidemiological story, you know, the numbers, how many people caught COVID at what points, and has a timeline within it that tries to creatively sort of retell what happened when for the historical record, when we were put into lockdown, when we went into our tier systems, etc. But it tries to also capture the voices of various healthcare professionals and staff, various members of the York community, our citizens, and tries to give a sense of what we went through as a city and what it was like to live in York during these last 2 years. It also makes historical comparisons because of its historical flavour. So 3 different outbreaks are considered from our history: the flu epidemic of 1980 to 20, the bubonic plague, and the cholera, the series of cholera epidemics that we had in York. And of course, you know, we have a connection to the man who did a lot to solve the cholera epidemics, John Snow, who was born not 200 meters away from this building. So the report makes those historical connections and tries to show that there were precedents for what we went through. And in fact, if we want to respond well to to subsequent pandemics, learning the lessons of history and having the right things in place are going to be very important. So in that vein, Sharon has set out a number of recommendations from her report to the city. And these are recommendations that Public Health will lead on the follow-up, if not all the implementation, because we won't be able to do everything. But we are recommending that we should seek to build on the citywide partnerships that we formed. If we think about the number of people that sat around the table for the Outbreak Management Advisory Board from a lot of sectors, we think about the number of people that were heavily involved in the rollout of the vaccination programme. Hundreds of people sat around those tables. So develop citywide partnerships partnerships to lead on a living with COVID approach for the city that goes beyond COVID and really thinks about how, as a city, we, particularly most winters, protect ourselves from respiratory diseases that are easily preventable through standard public health measures. The second is about the Health Protection Committee. For a number of years, we've shared a Health Protection Committee with North Yorkshire, but we are proposing here establishing our own City of York Health Protection Committee to cover all of the things I mentioned in my previous report, not just infectious diseases. The third is about children and young people and the schools survey, and we're recommending that the Children and Young People's Health and Wellbeing Programme Board use the findings in the survey to inform the development of the Children's Plan for York. And the fourth is about the wider impacts on health, physical and mental health of the pandemic, particularly thinking about some of the preventable factors: alcohol consumption, people's physical activity, smoking, their diet and connection, loneliness and isolation, and bringing people together and come together to work on focusing a preventative approach across the city to some of these issues. So hopefully that report is both useful and interesting. That was its purpose. It will go into the city's archives as our official record of the pandemic years in York. Thanks, Chair.
Thank you very much for that, Peter. Are there any questions to Peter on that report? So is the board happy to accept the recommendations made in paragraph 15? Is that agreed? All right. Thank you for that. And then, yes, we're darting around and my very focal glasses are struggling to keep up. Right, so we received the report, we agreed to these recommendations as from paragraph 15, and then note the progress being made on the recommendations of the 2019 Director of Public Health Annual Report. Are we all in agreement? Thank you. Right, that brings us on to item 14. This is Peter talking about the COVID-19 update.
Thank you, Chair. Well, I think we've tabled this for information unless there are any questions, because we've had an update on COVID rates throughout the pandemic to this board, and we decided a couple of meetings ago to move to a full information paper. So if it's okay with you, Chair, should we just go straight to any questions that arise, if that's okay?
Yes, so are there any questions to Peter? Jamila.
Just one quick one, Peter, as we go into winter and COVID is in somewhat becoming slightly normalised. How are we continue? I know we've got other groups where we continue to monitor COVID, and are we doing the same monitoring as we did when we had COVID, or has it been stepped down to somewhat? And how would we know when rates are increasing so we can prepare both through social care and health?
Thank you, Jamila. It's a really good question. And I'd probably say there's two things we're really looking out for this winter as a public health team. The first is that every week the ONS release an estimate of the number of people who have COVID, which is probably the best data point because it doesn't rely on people coming forward for testing, which is now not very available, but is a random sample of the population. So it's quite robust. I think the other thing, and I would also point to our graph, it's on my page 349, it's after item, point 31, is our excess deaths graph, which doesn't feel a particularly sort of enjoyable thing to focus on, but it is very important from a public health perspective because we know how many people on average die every week in York. We can look at the historical trends and whether or not it's deaths that are caused by COVID-19, by influenza, or by delayed healthcare because the healthcare system is under such pressure, we know that that will show through in our excess deaths. Now, I've been looking at this, and the last 2 or 3 weeks, we have had raised rates above the historical average. I'm glad to say, actually, on point 31 of that graph, there is a more recent graph that came today, too late for the papers, that shows our excess deaths for the most recent week that we have data for are below the average. So you have to be careful to not overinterpret. Things go up as well as down, but we are closely looking at the excess deaths to see if overall respiratory illness, for instance, is causing us more issues than we might be. The other thing I would mention is that in primary care, there are approaches being developed to try and test for COVID and flu at the same time using those lovely rapid flow tests we all remember. So that's not technology that it's actually being trialed at the moment, but that will give us probably really a better protection in future in the winter if those devices work very well. So just to mention that out of interest, but that's probably the 2 things I'm looking at.
Stephanie.
So just to say that we have a weekly tracker with our GP practices that looks to look at those national rates, but also local rates. But also alongside that, we report in primary care our OPAL rating, which is an escalation rating. So we go in and speak to general practice just to see why they are having escalation. And it is fair to say that while COVID numbers are very much reduced and we're seeing increased flu, we do monitor absences, particularly staff absences due to these infections as well, because they're having an impact. And just to say, it hasn't gone, our vaccination approach hasn't gone away. So we've just been out to do work with vulnerable groups. So we are out doing and trying to scoop up those people who have been reticent and working with different communities. So it's still they're getting priority attention because the vaccine is the best way to protect people from the impact and severe impact of the infections.
Sean and then Peter.
Yeah, I was just interested in, I had a conversation with a colleague who works in general practice recently, and they were predicting that we were going to be seeing an increase in COVID cases and flu cases around about now. And I don't think we've seen quite the lift in COVID cases, but we have seen the flu cases increasing. And it sort of tips back to the previous agenda items around public health messaging, and also the comments made about disabled people using our local transport options. And at what point do we tip back into having conversations about wearing masks, protecting other people, and thinking about how we can each play a role in maintaining our health in York? Because I know I've now got very used to the idea that I'll never wear a mask again, and yet I should be accepting of the fact that there's going to be points in time where it would be a helpful thing to do to minimise the spread of all infectious diseases, regardless of what their label is, to help protect our community and to reduce community infection rates. So do we have a clear idea in our heads of what that point would be and when we will start putting those messages out, and how we do that across the whole system together? Because I think they're not going to be messages that people will particularly want to hear. That doesn't mean we shouldn't be sharing them.
Thank you, Sean. I'll jump on the chance to say some messages that I think we could take now, which are that hand washing has been a wonderful public health intervention for centuries and continues to be very important. Ventilation continues to be very important, and we learned a lot about adequate ventilation for prevention of COVID during the pandemic. We'd be saying to the public, please expect to wear a mask when you go into clinical settings, and that's a very important message to get over, actually. And more broadly, be thinking about settings where you may be with those who are more likely to be vulnerable. And for some people, the pandemic really hasn't ended, hasn't moved on. And I think that is important to say that. In terms of a time at which masks will be more widely recommended and mandated, that's difficult to entirely predict. I've heard similar that COVID is now moving into a series of waves, and having had a peak around September, we could probably expect, just given the period interval between peaks, that we actually may see something again before Christmas or around Christmas. That's speculation, but it seems to be sort of based on what we have seen. And for flu, we know a particular sort of profile that people are this year and this season often younger, and it is leading to more hospital admissions, but the vaccine seems to be working well. We know that some people are worried about getting a vaccine because they're worried that it might make you feel a little ill. Actually, having a flu vaccine that provokes a little bit of an immune response is a good sign. It shows that it's done something well in your body, and actually it is a well-matched vaccine. So if you're in that eligibility category, and a lot of people are, getting those jabs is so important. That's probably, Steph said, the key public health message. But the speculation about when we might change, that's a bit harder to sort of answer.
Thank you. Councillor Looker.
Yes, I was looking again, vaccinations. I'm on page 348, and I find the chart a little difficult to read, but I'm presuming it's just snapshotty. But it is interesting, and I can't help commenting it as a councillor for Guildhall Ward. We always sit at the bottom, and it is reflecting. It's reflecting the social deprivations. It's reflecting. I notice Westfield comes equally quite low. It is reflecting those social disparities between the groups who take up vaccinations with enthusiasm and the groups that are very resistant and all very difficult to just get hold of. And I don't know quite what the answer is, but it does seem to me it's emphasizing the social disparities, which we keep talking about, but how we address them. And vaccination is a very good, easy sort of signal of where we are making a mark and where we're not.
I'm going to be quite bold and say I absolutely agree, Councillor Looker. I think without some work that particularly Steph and her team have led over the last couple of years, there would be even broader disparities in vaccination rates, because I think we actually have done quite a lot of work, both geographically, but also thinking about particular communities, people with a learning disability, I'd highlight as one thing, and lots of other communities to try and overcome barriers to vaccination, whether it be the convenience and accessibility of the vaccine, whether it be people's concerns over vaccination as a process, and try and tackle that. But you're absolutely right. It's still, the graph still looks wrong, doesn't it? It still reflects the social disparities that we do see. And I think we have to build into our vaccination programs year on year. And I think we've learned this through COVID, a vaccine inequality, a strategy, an action plan every time to say, how are we going out to take, you know, as my colleague Anita Dobson often says, the jabs of the arm, rather than, you know, expecting people to come to services that may be further away from where they live. So there's work still to be done, but I think we can definitely say there has been some good work on vaccine inequality.
I think if I can address my question to Stephanie, is appreciative of the work done for the vaccination at Cornlands at Priory medical group there, and the volunteering that goes on to make sure that that happens. I think if we can promote that message about the accessibility, then I think the last major vaccination campaign, there was more done in community centres, but that was as a consequence of having staff available to do that. That wasn't the case this time because more were in situ. So it's just understanding the messages that can be got out to say, actually, it is nearby, and you can more easily get hold of it.
Yeah, so the national strategy is moving towards a community pharmacy model. And so we've got a more dispersed model around the city, but we are responding to government guidance about which groups are targeted, and therefore that dictates the flow of the vaccine availability as well. So we've vaccinated our care group population. I think that's at 85% and above. And we're just working through housebounds as well now, as well as doing the general call up to our community clinics. Yeah, less scope to go in and you know, we did a lot with the students going into the yeah, it's just not fallen away, but we're, you know, we've moved on to discharge. We do our best.
Right, thank you for that. So if you can help with spreading the message about where it is available, then that will help take up. Okay, is the board happy to receive the report? And that brings us back to agenda item 11, report on the York Health and Care Collaborative.
Thanks. I think this is me again doing an impression of someone else. This time doing an impression of Dr. Emma Borton, who's a member of the board, who chairs, along with Dr. Becky Field, the York Healthcare Collaborative, and I sit on it, hence being asked to cover this particular item. The Health and Care Collaborative, I think, is sort of best seen as a group of sort of senior operations managers and people who work managing quite a lot of our provider services that sit outside of the acute bit of the hospital. So it doesn't, as a collaborative, really concentrate on planned care in the hospital or on urgent care in the hospital. It concentrates a lot on community services, on the work of our physios or OT services, how that overlaps with social care, and some of the prevention services. So colleagues like Joe, who's now left, and Michaeli sits on the group, as do a lot of public health services. And that's the sort of professional sort of grouping that comes together around this collaborative, meeting every month. It's chosen, and I hope the board will be pleased to know that it's chosen to focus next year on the health and wellbeing strategy. And we will have 10 meetings, and so we have 10 areas or goals in the strategy. We decided to just cover the 10 goals, and so we will be working our way through those next year, which is very positive. It has a number of working groups, one around aging well, one around frailty, and one around multimorbidity, which I won't go over too much of the work they're doing, but just to talk a little bit about some of the frailty work and some great actions there about the use of something called the Rockwood scale, a way of identifying people who are frailer and assessing and grading them essentially on a scale. And the point of that is not to give people labels, but to actually say, if you are at a certain point on the Rockwood scale, this is the type of service that you're going to need to prevent you from deteriorating and to keep you fit and well and preventing a hospital admission. So in particular, we've been working with colleagues in primary care and in the council on a frailty assessment unit at Acomb Garth, and better use and training on that particular score, which we really hope will improve services for those who are frail in the city. We've also done a lot of work on deprivation and cost of living, and out of that, quite a lot of actions that are starting to be delivered on an action plan about how the healthcare services in the city can be better at supporting people with cost of living issues, be it the condition of their housing, be it their financial inclusion, that incredible resource we have about the number of people every day that come into contact with a healthcare professional in York. How can every healthcare professional know about York Energy advice or know about our financial inclusion work? We know that there are missed opportunities there. So YHCC have been managing an action plan on that, and looking at that link between deprivation and health, and how we can look to tackle that through the work of the group. And it is very action focused, YHCC. And so we, for instance, just in terms of staff well-being, helping some of our lower paid healthcare staff with funding blue light cards, which are a £5 each. It sounds a tiny amount to some, but for actually others, that might be a really sort of helpful amount of money. We're doing work around a children's ambulatory treatment hub, which is trying to avoid avoidable admissions for children and attendance in A&E when parents are worried about their children's health. It can be very tempting to phone either A&E and to find yourself going in, or phoning 111, which can be very cautious with children, but actually having a hub to be able to take your child to get a medical assessment that is not in the hospital is shown to be quite an effective model. So that's been established through this work. So lots of things that are noted in the paper that I could go over, but I won't in interest of time, but just an update on the work of the group, Chair, for people to be aware of. It feeds as a group into this board. So it's just to update the board on that.
Thank you for that. I just wanted to ask in relation to Annex A, there was a comment on page 1 of that as a result of the workshop, YHCC asked the Health and Wellbeing Board where it thought the gaps were in supporting deprived communities in York. And I have a lot of views about that as a ward councillor. We've touched on that before, Peter, but I think it would be helpful to circulate that question widely and then to provide the feedback. I appreciate that there was a session at the Guildhall with a large number of partners there, and that was very productive. And therefore, I think to capture that and then to evidence the responses to that would be helpful. Martin?
I just note from the minutes that there's a representation from the council, but from adult services, I just wonder whether obviously safeguarding social work services for children come into contact with the majority of the population that are certainly could be classed as being within poverty. It would be good to have a rep. We'll have a specific thing.
Thank you, Martin. I think that'd be absolutely welcome. I'll take that to the chairs and connect the right people.
Okay, any other points on that? And we're also asked how we can assist health and care partners in York to put additional support into services helping those experiencing high levels of health and non-health related anxiety. I presume coming out of COVID.
Yes, Chair, this was something that came up through the workshops, that we know that some of the demand that we see on every part of the healthcare system is as a result of people's awareness of health and health issues, and potentially helping the population to restore that some of the pre-pandemic sense of self-management and going to the right place for the care and support they need. You know, many people have very real health issues that they need the healthcare for, but I think, yeah, it was a comment and a piece of feedback from that survey that people wanted the Health and Wellbeing Board's input into that sort of health and non-health anxiety that we can focus on.
Okay, we'll circulate an email as to how that can be collated, so that that information request is adhered to. Any questions on that report? Are we happy with those additions of requests for information? Which will be, I think the action point will be an email will go out. Yeah. Inviting comments to those 2 points, and I would be grateful if people did respond promptly to that from their organisation. We agree that report? Great. So we're left with any urgent business. There is none, so I bring the meeting to a close. Thank you all for your attendance.